Hello, everyone. My name is Stephen Orbeck. I'm a MSN student at Eastern Kentucky University and a current psychiatric registered nurse. I want to talk a little bit today about my project proposal. Um, you know, to define this healthcare problem here locally, um, all we have to do is take a look at the statistics here in New Mexico. And according to the New Mexico Injury Prevention Statistic Plan of 2016, New Mexico's ranked 84.4% higher than the rest of the U.S. population in adolescent suicide. That in itself is enough evidence to support the fact that we have a serious problem here locally that needs to be addressed. And working as a psychiatric RN over the years, I'm seeing an increase in these kids that are coming in. You know, they come in, we treat them, and a month, maybe 6 months later, they come back and they're worse. So as a nurse, I have to sit there and ask myself, well, what are we doing wrong? What can be done to help these kids that are depressed and suicidal? So what I want to do is propose a project that includes the use of CBT in conjunction with, current methods, medication, to help these kids gain some insight into their depression, their thought processes, to gain some coping mechanisms that they can use and lean on, during their times of depression. The target audience for this is adolescents aged 12 to 17 that are diagnosed with depression or major depression. And as advanced practice nurses, this is a significant, this is of significance to us. This is something that, as providers, it's our responsibility to be sure that our patients are receiving the best treatment that we can provide. Often we are the final, we are it. We're the provider. We're the final step. It's our responsibility to get these numbers down, to make sure that whatever depression these kids are going through, it's up to us to help them pull themselves out of this. So what I began doing was I started looking at different randomized controlled trials. I found 4 in particular that covered a wide range of different populations that, I've seen these kids fall into. One of particular interest was treating kids that were diagnosed with autism spectrum disorder, that were higher functioning. And CBT in that article proved particularly helpful in decreasing anxiety symptoms. These kids were, reported less anxiety, higher functioning at school, better social networks, and overall seemed to interact better in comparison to the treatment as usual group. Another RCT I found was that, kids that had PTSD were exposed to trauma, sexual trauma, physical trauma. The CBT arm of that group also showed favorable outcomes. Young women who, are extremely poor, living in rural populations, they also showed in the outpatient setting, in community settings, that CBT in conjunction with medication showed to be favorable with these kids, or with these young women. That being said, with all the evidence that's pointing towards the positive nature of CBT, I want to propose the following intervention. And that intervention is to provide cognitive behavioral therapy at a minimum of 2 hours per week in conjunction with current medications used to treat adolescent depression to see if there is a greater benefit to adding the CBT component. Again, the target population includes adolescent boys and girls aged 12 to 17, diagnosed with depression or major depression, but yet excludes those with any component of psychosis, mood disorders, conduct disorders, personality disorders, and the kids in this group, I feel, should have a GAF, or Global Assessment Functioning score, greater than 50, and an IQ score greater than 50. The intervention would include these kids receiving 2 hours of CBT during their inpatient stay, and then those 2 hours being the 2 hours per week being provided on an outpatient level over a year's period. The proposed evaluation measures I want to use for this are the CESD scores, or the Center for Epidemiologic Studies Depression Scale. You know, it's an easy scale to use. It's something these kids could understand. It's in their language and take advantage of. So before they start the CBT, we'd get a baseline score. Then 6 months later, we take another score. And at a year, we take a look at the final score to see how the kids receiving the CBT score and how they're functioning, you know, within the day-to-day activities of school, family, social networks. I feel that according to the current evidence that's out there and how broad of a tool CBT is, that we should look at this and we should try this. You know, as providers and as nurses, we owe this to our patients. You know, we need to get these rates down. I want to thank everybody for taking time out of their day today to listen to my project proposal. And if you have any questions for me, I'll be on the discussion boards. Thank you.